welcome back to our series of webinars. Uh, Alhamdulillah, the topic for we have a good speaker today. Yes, just a second, please. Just let me share my screen.
Hello, Dr. Shiraz, can we hear you?
We can't hear you.
Dr. Shiraz? Dr. Shiraz? Hello? Dr. Shiraz?
Dr. Shiraz,
Yes,
we
ma'am.
can't hear you.
We couldn't
Okay,
hear
now is it
you. Yeah, you need to start and then because we missed
okay?
you starting.
Okay. Is it audible now, ma'am?
Yes, yes. Okay, please start.
Okay.
Yeah.
Okay. Is it audible now, ma'am?
Yes, yes.
Yes. Okay. Assalamu alaikum warahmatullahi wabarakatuh. Good morning to all of you. Let's begin with today's webinar. The topic for today's webinar is Beyond the Basics, Updated Techniques in Resective Osseous Surgery. We have today with us an amazing speaker. I will give the introduction of the speaker later after some time. Later the people join. So let me give a quick introduction to the topic. So, resective osseous surgery, right? The damage resulting from the periodontal diseases manifests itself in a various destruction of tooth supporting structure, right? So, conventionally, bone loss has been classified as either horizontal or vertical bone loss. But in fact, the bone loss is most often a combination of horizontal and vertical. Okay, so the horizontal bone loss generally results in thickening of the marginal alveolar bone because the bone tapers as it approaches the most coronal part. So this effect of this thickening and the development of vertical defects leaves the alveolar bone with countless combination of bony shapes. If these various topographic changes are to be altered to provide a more physiologic bone pattern, a method of osseous recontouring has to be followed. So now we will see the definition of osseous surgery. What is osseous surgery? The osseous surgery may be defined as the procedure by which changes in the alveolar bone can be accompanied to get rid of the deformities which is induced by the periodontal disease process. So osseous surgery can either be additive or it can be reductive. Additive is nothing but regenerative. Okay, so the additive or regenerative osseous surgery brings about the ideal results. Okay, the results include the regeneration of lost bone, re-establishment of periodontal ligament, gingival fibers, and junctional epithelium, which is at more coronal level. Okay, what is resective osseous surgery? Resective osseous surgery is an alternative to additive methods, and it should be used only when the additive methods are not feasible. Okay, this is the resective osseous surgery is done at the expense of removing of alveolar bone. So, resective osseous surgery provides the surest method of reducing the pockets and is based on the tenet that discrepancies in the level and shapes of the bone and gingiva predispose the patient to the recurrence of pocket depth post-surgically. Its goal is to reshape the marginal bone to resemble that of the alveolar process which is not damaged but is undamaged by the periodontal disease. This procedure eliminates periodontal pocket depth and improves tissue contour to provide a more easily maintainable environment. Okay, so it was a quick introduction. Just let me give you the gist of this introduction. Okay, so probably we have two things to remember here. Okay, one is the additive osseous surgery and one is the resective osseous surgery. The additive osseous surgery is usually the surgery which we regularly practice in clinical practice. That includes bone grafting. It may include your GBR procedures and everything. But resective osseous surgery clinically, I'm not sure how many of us are doing this resective osseous surgery apart from doing the clinical crown lengthening and so. But the proper resective osseous surgery where you have these four steps. So let other people join and we will discuss it in the later part of the webinar. Okay. Now let me introduce our speaker. Okay. Dr. Fahiza, she has completed her graduation from, just a second, I need to open her. Yes. Just a second. Yes, Dr. Faiza has completed her graduation from Ramaya University in 2017, and she has completed her master's from Yenukoya University. Currently, Dr. Faiza is pursuing her PhD, specializing in periodontal ligament cells, stem cells, and working actively on research in oral cancer patients. And very interesting fact about Dr. Faiza is she is the winner of MSME Women Hackathon 3.0, and she has been granted 15 lakhs from the government of India. She has and she is the chief consultant in various private clinics and one hospital, and also she has research and experience in research and grant writing. She has 18 submissions to national and international agencies. She has successfully secured funding from various agencies, and she has received two prestigious awards, a notable shortlisting from the Department of Biotechnology, Government of India. Okay, Dr. Faiza, here you go. The podium is all yours now.
Thank you so much. Thank you so much for that wonderful introduction, as well as about the resective osteosurgery as well. So, can I
Dr.
start the sharing?
Yes.
Ma'am,
Yes, yes, go ahead, go ahead.
okay, thank you. Also, it's an honor to be present here to speak in front of such a beautiful community. So, let me just share my. Is it visible?
Yes, yes, Dr. Faiza, it is visible. Yes.
Okay, perfect. So today my main topic of
Dr. Faiza,
discussion
can you
is,
just expand your screen? Can you maximize?
I think it is maximized. It's in full. Is it not in full screen?
No, it is visible, doctor. It is visible.
Okay.
Okay.
Yeah.
Okay, so we will be talking about the basics of the resective osteosurgery. As let's just probably revisit what are the techniques and what are the available chances of having a resective osteosurgery in daily lives. Probably the basics of it will cover today, and what are the updates which happened in the past few recent years about this technique. So we'll be talking about that, and I'm Dr. Faiza, as Dr. Shiraz nicely introduced me. I'm from Yenapoya Dental College. I'm currently pursuing my PhD in periodontal ligament stem cells, and also having other research work ongoing on oral cancer patients and radiation biology as well. So, coming back to the topic, resective osteosurgery. So first of all, before starting a resective osteosurgery, as before explaining, let me tell you about my personal experience on this patient. This is a patient who came to me during my post graduation. So this was a very interesting case, probably my first resective osteosurgery case. So I just wanted to include this in the beginning to know what are we getting involved into. So this was a patient. She was a 32-year-old female patient, and she came with the chief complaint of food lodgement in her upper right molar tooth region. So on examination, we found that there was a 5 pocket, periodontal pocket in the distal aspect of 1.5, and on the mesial aspect of 1.6, we found there was 7 pocket, and then on the distal aspect of 1.6, we saw that there is 6 periodontal pocket. So on radiographic examination, we found probably I'll just use a laser here. Yeah, we found a proper angular defect which is seen on the mesial aspect of the 16. So how do we go about this? Like, so our treatment plan was surgical opening, flap debridement, and since we found that there was that extra bony exostosis, probably we can use that bone to regenerate the bone around this area. So that was our aim for this case. So after that, as usual, we did a surgical opening. For this, we took a minimally invasive technique using only a single flap approach. We only approached through the buccal aspect. We didn't go through the palatal aspect. So this was one of the modification by Trombelli et al. Like a few years back. Instead of opening both the sides, the flap, and simply work. Probably taking too much of the bone from the bones both sides, we used a single flap approach. So we did a circular incision, we opened the flap, full thickness flap was raised, and this was a defect which was seen. So if you see this defect, you might see the extensively bony exostosis. But let's see what are the actual osseous defects seen over here. Okay. So if you see first thing, maxillary exostosis. Maxillary exostosis usually happens because it is developmental aberration, but it can happen because of a periodontal disease or an occlusal forces. Probably a continuous occlusal force can cause a buttressing formation on the bone and has a thickening of the margins of the bone. So this was, if we are explaining this as maxillary exostosis, the next, if you go to see, there is bulbous bony contours. So this is a problem for us aesthetically, as well as this bulbous bony contours can lead to all these defects over here. So that is difficult for us, like because it'll be more prone to the periodontal diseases at those points. So elimination of this bulbous bony contours also becomes very important over here. Then if we talk about oh, yeah, if we're talking about ledges, so what happens is because of the thick bony margins over here, you can find the alveolar thinning of the bone at the marginal ends. So that becomes like a ledge kind of thing. So when you have a ledge kind of thing, nicely all the things like periodontal pathogens can go and build a house over there and stay there forever kind of thing. So periodontal disease will start growing over there as well. The next probable defect over here is the vertical bone loss, which we also examined radiographically as well. And it was a 3-wall defect, which was seen in the radiograph as well as clinically. Then we have the horizontal bone loss, which is seen. Usually, as you have seen so many cases of horizontal bone loss, so the along with the resective osseous surgery, we'll have to see how to attain a positive architecture. So what happens is horizontal bone loss becomes problematic when the interdental bone comes below the buccal bone. So it is always to have the positive architecture. So if I have to tell the positive architecture, it should go like this, right? Along the scalloping. So your interdental bone should be always above the buccal bone over here. So when that happens, when you lose that, that becomes your horizontal bone loss. Okay. And then inconsistent margins. You cannot have an inconsistent margins to have a smooth flap adaptation. So that has to be eliminated. Then again, as I told you, negative architecture. So here we can see that the interdental bone over here is lower than the buccal bone. Not happening. That cannot happen. We have to get either in this, probably you won't be able to get the interdental bone to an upper level, but probably you will have to get the buccal bone to a lower level. Okay, and the final one is the interdental crater. We saw a small crater which is happening in the interdental bone area. Now, technically, what are the other osseous defects which you see when you open a flap? Like in generally, when you do all these kind of cases, one is bulbous bony contours. Now, these are all developmental osseous aberrations. If you have to see, they are not caused because of the periodontal disease as such, and they won't cause you much harm as such, but probably aesthetically, if you want to make it look more appealing, or for elimination of future periodontal disease, you can correct these defects. Then other than that, again, as we have see, can you see the buccal exostosis? It's a maxillary exostosis. Again, in this case, if the patient has no problem, you can still stick to it, but it might have chances of future periodontal diseases, more chances. And of case. Then we have the lingual tori, where a patient has is not able to, like, there are the tongue is coming in between, and they're not able to maintain the oral hygiene. We'll have to remove that as well. And of course, the palatal bony contours as well, palatal exostosis. Then coming to the other developmental effects, fenestration and dehiscence. So fenestration is a osseous defect where the marginal bone is intact, but you can see
Hello? Yeah, did we lose Dr. Fahiza? Hello? Dr. Fahiza? I think we lost
Yeah,
connection. Yeah, we lost
yeah,
connection with her. I'll just connect with her again.
yeah.
Dr. Fahiza will be joining us soon. There's some technical glitch. I apologize to members. We're just waiting for Dr. Fahiza to join. Yeah, I'm just connecting her back. Yeah, Dr. Fahiza, we have you back.
I think something went wrong with my internet connection. I'm so sorry about that.
No issues, no issues. You can continue, doctor. Some four
Okay.
slides, I think we missed your audio as well.
Oh, okay.
Yeah, yeah. So, I mean, I think
Uh,
Dr. Shiraz can help us from the slides. If you can
Yes,
read
yes,
that.
yes.
Yeah.
Can you
yeah, one.
just go back to that fenestration and dehiscence slide, please?
Yes, this
Yeah, we
one, right?
lost the connection from that side. Yeah, yep.
Okay. I'm so sorry about that, but let's get back. Okay. So we have another developmental defect which we see is fenestration and dehiscence. So fenestration, again, it's an isolated area of an osseous defect where the marginal bone is intact. Like if you see over here, this portion where the marginal bone is intact, that becomes your fenestration. And this, where the marginal bone is not intact and the osseous defect is extending into the alveolar bone, that becomes your dehiscence. Okay. So again, if you see in a clinical point of view, here probably the canine it is. Here you can see an isolated area of osseous defect, and that becomes your fenestration. Here the marginal bone is breached, so that becomes your dehiscence. So now again, I'm putting it as acquired osseous defects, aberration or defects as well, because of the reason being that this can happen because of periodontal disease as well. It can be acquired because of the periodontal disease as well. The next defect is the marginal bone defects. So as we see, this is the actual positive architecture which we see over here. Now, if you have to see the negative defects, if you come to this below picture over here, can you see that interdental bone comes below, then the buccal bone is up, then again interdental bone goes up. So that becomes your negative architecture. And then, of course, the flat architecture you have almost in the similar kind of line. Then coming to other kinds of osseous defects which you may come across, one is a marginal gutter. So all these are in the buccal and the palatal aspect only, these defects. Okay. So this is a marginal gutter, can you see over here? And then you can see a ledge. Actually, interdental crater is an interproximal osseo defect. By mistake, it's come here. Uh, then coming to the interproximal other osseous defects can be the horizontal bone loss. Most of the cases we would have seen in radiograph or clinically as well, the horizontal bone loss which is seen. And vertical bone loss, where you have this is the two wall vertical bone loss, where the two walls are present. Here, there's only one wall present. So it becomes your one wall defect. And then here, all the three walls are there except for this portion. So that becomes your three wall defect. And there's something called as trench, like a nice trench kind of defect, which is seen around the molar over here. And or a moat. Moat is a circumferential defect, which is seen around the tooth. Coming back to my case, so the previous what we have discussed is what are the various other osseous defects which we'll be encountering in our clinical cases. But what we have done in my cases, we have opened the flap. We saw a defect, angular defect on 1/6. So we saw this bony exostosis. So we crushed the bone over there using a bone ronger. We did an osteoplasty procedure as well. Now, when you do an osteoplasty surgery, here I have not well defined the steps in resective osteosurgery as I've done, because I don't have good pictures of that. So let me brief about what actually resective osteosurgery and what are the steps are. Okay, so first of all, vertical grooving. In vertical grooving, basically it's also called as festooning, and you kind of give those vertical grooves in between the root areas. You cannot do this on the root. It should be on the line angles of the tooth sides. So basically, in below the interdental region, you do the vertical grooving. In minimal cases, only vertical grooving is required, and where like you have the bone over there and you just do the vertical grooving in both sides, like on the lingual and the palatal sides as well. Then comes the radicular blending. So in radicular blending as well, we have done the vertical grooves. Radicular blending is not done in all cases. If it's a very minor defects or marginal bone deformities which you see, then you can just round in with the vertical grooving as well. But in case it's a thick bony margin, then when you do vertical grooving, there are sharp edges over there. So you need to blend the sharp edges which has been created with the because of the vertical grooving. So yeah, so we do the radicular blending. Let me just see this. Then coming to the interdental, okay, so the previous two surgeries which we saw, that is vertical grooving and radicular blending, they are only the osteoplasty procedures. We don't go into the supporting bone of the teeth. It's just the non-supporting bone where you're just recontouring or reshaping of the bone is done. Coming to the interdental flattening of the bone, here this is an ostectomy procedure. So sometimes what happens is there is an interdental bone defect as well, and you have to flatten it out of there, because here you can see the vertical groove defect. Now you have to flatten this much to get better adaptation as well, and to get the proper contour for the final scalloping of the gingiva as well. If that is not being done, again you might have more you might have caused more defect over there if the flattening of the interdental bone is not done. Then you do the gradualization of the margins. Now, again, this is the final architecture which we need to obtain. Now, the interdental bone is over here. So we have to get the interdental bone at a level which is above the buccal bone. So to get the again the final adaptation of the final adaptation of the flap, surgical flap. So what we do is when we do the marginal, so we keep the see correct. So here we ended up compromising the tooth over here, compromising the bone structure around the teeth. Okay, because we have to get it at the level to get the final contouring of the bone. So here we have ended up doing a flat architecture, but over at this portion you can get the positive architecture over here. So here care has taken that it is not involving the furcation, so we have made there also a positive architecture. I'm audible, right? Like everything is clear, right?
Yes, doctor. Yes, go ahead.
Okay. So to brief out, this is the steps in resective osseous surgery. So when there is a bone defect over here, we do vertical grooving so that we get a final outline of the bony contour, and then we do the radicular blending at these portions where the sharp bony margins are, and then we do the flattening of the interdental bone is done over here so that we get the final contour of the positive architecture, and then we gradualize the bone, gradualization of the marginal bone. So these were the basic steps, and after this is again coming back to my case. We had filled the defect with the bone graft over here. We placed a collagen membrane over that, and then we have sutured up this case. So after 1 week post-op, this was the initially how the patient came with the buccal exostosis, and this is where we got the nice contour of the gingiva when it was nicely adapted to the tooth. So let's dive into resective osseous surgery. What is osseous surgery? Any kind of uh, deformities you're adjusting in the alveolar bone, or any kind of surgery being performed on the osseous or alveolar bone, that is called as an osseous surgery. Now, osseous surgery, again, as I think Dr. Shiraz nicely explained previously in the introductory session, there are two types. There is resective osseous surgery and inductive osseous surgery. So resective osseous surgery, subtraction, so any kind of removal of the bone is called as resective osseous surgery, whereas additive osseous surgery is regenerative. You're regenerating the lost bone over there. You're establishing the bone to the original contour, re-establishing. But again, what I would say is, I think there is some amount of resective osseous surgery done even when you're doing the regenerative osseous surgery. You cannot achieve regenerative surgery completely without eliminating the bony deformities. Like imagine you have a bony deformity, and just on that, if you're putting a bone graft, it's not going to work out. You have to smoothen the bony defect over there, and then only you can add the regenerative techniques over there. So some amount of resective osseous surgery will be done before gaining the regenerative or before doing the uh, uh, regenerative procedures. So again, in resective osseous surgery, you have two types. One, you have the definitive osseous surgery and compromised osseous surgery. Now, definitive osseous surgery is very straightforward. You do osteoplasty to get the final contour of the teeth. You're not compromising on the tooth's supporting bone. You're just reshaping of the non-supporting structure. So it's a definitive kind of osseous surgery. Now, a compromised osseous surgery is done when you are compromising the supporting supporting bone of the tooth. Example, if you see this defect over here, now we have to get the final contour, and for that you have to take probably this much of the bone over here, which is actually supporting the bone, but you need to get a ideal contour where the interdental bone is at a higher level. So you're removing this much of the bone, so that becomes your compromisation of the supporting bone of the tooth. So that is the two types of resective osseous surgery. Now, why is osseous resective surgery actually done? Or like, what are the objectives? What is the rationale behind doing this? To eliminate the periodontal disease area or removal of any osseous deformities for maintaining the proper osseous contour so that there is elimination of the progression of the periodontal disease. Now, creation of the physiologic parabolic contour. This is a nice outline which you can see of the positive architecture. So, this has to be the final outcome of what we are looking from an resective osseous surgery. Now, again, if you see in this picture over here, there are so many bone deformities. Like you can see a isolated window kind of fenestration over here. You can see a dehiscence over here. You can see that here there is a defect on the distal aspect. So all these areas are potential for for the accumulation of the periodontal pathogens, which further will progress into further resorption of the bone and then mobility of the teeth and all that. So in each of these cases, to remove these osseous deformities, that is the main goal, so that the periodontal pathogens are not like, they don't harbor around there. Basically, elimination of the periodontal probing depth or pocket depth. So, according to the World Workshop in Periodontics, there are indications for a resective osseous surgical pocket therapy was root access to gain these access for calculus removal or subgingival deposit, or even manage the persistent deep pockets. Then for regeneration therapy, again, like when as I told you, like to do any kind of bone grafting or something, some amount of reshaping of the bone has to be done so that the bone graft which is being there can hold properly. And then corrective osseous surgery, any exostosis or any other deformities on the marginal bone as well can be recontoured or reshaped to the bone level. And periodontal abscesses and enhanced restorative and prosthetic and cosmetic procedures. Now, I think this is one of the most extensively used here, because crown lengthening, I think most of the clinicians are doing. So that becomes one of the indication of resective osseous surgery. So the final goal of resective osseous surgery is elimination of the periodontal pocket, to have a fewer bleeding sites, of course, and basically to shift these periodontal pathogens, especially from a gram negative to a gram positive anaerobes. Now, how do we diagnose this? So, I'm sure like everyone has heard about transgingival probing and bone sounding. We take a probe and just go along the sulcus in a walking probe method to find out if there is any osseous defects which is seen. So this allows it for the clinician to determine what is the osseous topography, where are the interbony defects present, is it one wall or two wall or three wall, furcation involvement, root shape or form. This alone cannot define the osseous defects. Along with this, we will take radiographic evaluation and correlate with the clinical evaluation as well. Now, what are the factors which we consider before this? First of all, the severity of the periodontal disease. We need to see how much of the periodontal disease is there. If it is like extensive periodontal disease and there is like grade 3 mobility level kind of periodontal disease, there's no much scope for only resective osseous surgery. Probably less severe periodontal disease has more or better outcome for these kind of resective osseous surgery. Then again, patient systemic health, and then patient's expectations, or how their oral hygiene is, all that is a patient related factor. Coming to clinical factors, bone morphology. We need to see if it's already a very thin alveolar bone, and if there is already a fenestration or dehiscence or something like that, any existing thin alveolar housing, we need to take care while doing this resective osseous surgery. Then the root anatomy. You cannot do extensive osseous recontouring on the root surface because it's already a bulging contour over there. So the most of the contouring has to be done in the interdental area. Then the soft tissue conditions has to be checked, like if there is any active inflammation, all that needs to be checked, and the occlusal factors. Coming to surgical considerations, again, each kind of surgery per se, it depends from patient to patient. Like when you open the flap, that's when exactly you get to see what kind of osseous defect is there. So then and there, you'll have to figure out like how to get the optimal environment for stoppage of the periodontal disease. And the different kinds of choices of surgical technique and the bone grafting which is being done, and what are the soft tissue management, all these are the factors which needs to be considered before the resective osseous surgery. What are the different armamentarium used? So hand instruments, we have chisels, we have Ocean chisels, that is like probably the one of the standard which is used for ostectomy procedures. Then you have curettes, elevates, forceps. Then in cutting instruments, we have scalpel, surgical blades, bone removal, we have osteotomes, rongers, which we had seen in the first, that is the bone ronger. Then what are the recent advances? Of course, we have piezoelectric units, diode lasers, carbon dioxide lasers, piezoelectric surgical units for bone removal, all that other recent armamentarium which has been come. Coming to the flap adaptation. Now, this is one of the very important thing when we have to consider when we are looking at the resective osseous surgery, the final goal is the flap adaptation to the underlying tissues. So when you're starting the procedure itself, you need to have an idea how the final look is going to come. So that exactly in that, like if this was a bone over here, they have improved this much of they have done this much of the osteoplasty surgery. That's because the final adaptation will come to this level over here. So based on that, they have removed the this much of the bone level over here. So it's called as the biological shaping of the bone. Coming to the brief history, it was started by Goldman in 1950 with the development of the physiological gingival contours, probably by gingivoplasty. Then Schluger, who also considered osseous resection because to get a nice osteoplastic contour as well. Then Friedman in 1955 told about the periodontal osseous surgery, which is he divided it into osteoplasty as well as ostectomy procedures. And Pritchard, the infrabrony technique as a predictable future, and Goldman and Cohen in 1958, the intrabony pocket, which showed us the classification and the treatment for each kind of defect. Ocean the osseous reductions happening in the periodontal surgery, and again a primer for osseous surgery. Now these are the pioneers in this field, resective osseous surgery. But what happened like in the future? Like what are the recent things? So GTR, guided tissue membrane, was a recent upgrade on the resective osseous surgery. Different kinds of collagen membranes and other kinds of scaffolds were put in across to see which has ideal requirements for a regeneration of the tissues. And then we have computer aided crown lengthening procedures where they tell like how much of osteoplasty is required, how much of ostectomy is required, and then of course the laser treatment as well. And most of the things like the future is looking forward to minimal invasive surgical technique, like minimally how you can get maximum outcome of it. So I think Carnival in 2007, he came across something called as fiber retention osseous resective surgery. Now, in this, what they do is the supracrustal fibers which are around the teeth are untouched. Other than that, everything else of the bone deformities are resected. So, example, let me take this case over here. So, this was a case done by Styling, I think, Dr. Styling. So there is a bony defect you can see at the mesial aspect and the distal aspects. The radiographic evaluation also showed the irregular bony margins. And then there was a flap elevation. So when the buccal flap elevation was done, it was made sure the supracrustal fibers around the tooth area was untouched. So over here, they have taken from the lingual aspect, if you see, they have taken a submarginal incision. so that the gingival fibers around the supracrustal areas are not used for your resective osseous surgery. Then see, so these are the bony defects which was earlier there. So can you see there are still some tissues left around the tooth over here which are untouched. So these are the supracrustal fibers which are still untouched around the tooth areas. Then they did all the removal of the bone defects over here, and like to get a better and smoother contour of the bony defect. But again, very minimal of the soft tissue around the tooth is used up over here. So this becomes your fiber retention osseous resective surgery. So this was now more and more people are using this technique so that there is better adaptation, there is better wound healing which is seen, there is faster and there is better adaptation of the flap as well. The rebound phenomenon is better of the tissues. So coming to the next treatment, like probably an interdental crater, if you have, how do you treat that kind of osseous defects? I think this is one of the most unnoticed osseous defect, but it's a very important one because you get a nice crater kind of deformity over here if you see. So what has to be done? This much of the bone has to be removed so that there's no scope for it to have a crater-like formation. So if you see from the buccal aspect, you can see that this is the positive architecture which was planned. So these end sharp edges are called as widow's peaks. So we'll have to eliminate these. So using an ocean paint chisel here, they have eliminated to get a final contour of this. So this is one of the treatment for interdental crater. This is another clinical case which is there, and this was a interdental crater which is seen over here, and you can see it is filled with bone graft, and we have sutured it up. So this is the decision tree. First, we have to see what is the periodontal defect after initial therapy and occlusal adjustment. We have to check for probing depth, bleeding on probing mobility, what are the radiographic and clinical assessment. And then we see if it is less than 3 mm, the probing depth, then we have to see the strategic value of the tooth, ability to control the secondary occlusal trauma, possible endodontic and orthodontic management. Now, again, if the probing depth is less than 5 mm and there is no bleeding on probing, probably a non-surgical treatment would be enough. But if there is bleeding, a probing depth of more than 5 mm, you need to see what the patient wants regarding the aesthetic concerns and then the manageable osseous architecture. So all that, like more than 5 mm, probably you can consider osseous surgery with resection, but favorable prognosis for this kind of treatment. Now, coming to the C part, where you need to prioritize, like appropriate defect is more than 3 mm and there is a 3-wall defect or a circumferential wall defect, like a proper intrabony defect, then again we have to check the strategic value of the tooth, like how important is the tooth at that point, then the defect morphology, how to control the secondary occlusal trauma, possible endodontic and orthodontic management, other systemic and behavioral issues, and the prognosis and patient desires. So these are the factors which will determine the next treatment for this. Now, in case the patient wants the treatment and but there is controllable occlusal trauma and there is favorable prognosis which you can see from the teeth, then you can go for a regenerative therapy over here. But in case the patient wants replacement of the teeth, he doesn't want to keep the teeth, or there is poor or hopeless prognosis of the teeth and unfavorable endodontic status as well, then better to go for extraction. So this becomes your overall decision tree to go for a resective surgery or extraction or regenerative method. So that is one of the way. Then other recent updates, let's just have a look. So this is like the stability of the gingival margin after aesthetic crown lengthening procedure in the anterior region. So here, I think we have actively been doing this in all of our clinical scenarios where we do crown lengthening procedures. probably we stick to only gingival crown lengthening because that's the easiest way for us to do the crown lengthening, and we don't stick to the biological width and biological maintenance of this. But it is so very important because it can cause further recession, and you're not achieving the final goal of the aesthetics as well for a long term. So here, aesthetic crown lengthening procedure, releasing the flap up to the mucogingival junction with a more than 3 mm distance from the bone crest to the gingival margin. So at least 3 mm distance has to be there from the bone crest to the gingival margin. That can lead to a stable gingival marginal position. So this article I portrayed here because it is again re-established in the recent years that at least 3 mm of difference has to be there in the bony, like between the bone crest as well as the gingival margin. This is another case done by Dr. Theo Katsaros. So he has nicely shown the crown lengthening procedure over here. Like if you see, this is how the patient has come, and this was the initial level of bone crest and the final gingival margin difference. And there was nice bone recontouring or osteoplasty, which was done to recontour to get the final adaptation of the gingiva. So this is one of the main consideration we should all consider when doing a crown lengthening case. Then, with or without fiber retention technique, of course, osseous resective surgery is the gold standard for removal of the any bone deformities. But with fiber retention, it has been shown similar kind of probing depth reduction, less osteotomy surgeries, less clinical attachment loss comparatively, and the better patient less patient morbidity or less patient comfort as well when compared to that of the resective osseous surgery. Of course, this happens because there is faster wound healing as well when there is already a gingival fibers present around the tooth and there is a gingival adaptation over it. Then coming to the traditional versus fiber retention resective surgery. Here, this was another review which was recently done, 2022. They told that base of the intrabony defect to a more coronal position, thus making a shallower and more easily eliminated with minimal resection of the supporting bone. So again, they have told that it has similar clinical outcomes to the traditional osseous resective surgery, with less osteectomy and less clinical attachment loss. So this is a more approachable technique recently which has come up for resective osseous surgery. Then, effect of post-surgical flap position on the soft tissue regrowth and keratinized tissue. So the apical repositioning of these kind of surgeries definitely it increases the soft tissue rebound as well as the keratinized tissue width, especially even at the interdental sites with the reduced patient discomfort. Then this was a very recent technique which was used by Trombelli. In 2024, he published this. This was a single case. It is also called as minimally invasive pocket elimination surgery, MIPES, which is just come up. So it is like basically an access flap based on an internal bevel gingivectomy with minimal or no papilla mobilization at the buccal aspect, and a resective procedure with an apically positioned flap on the lingual aspect. So the interdental bone defects were assessed with only a single flap, and the bone architecture was modified by the adaptation of a piezoelectric inserts. So so he found that from the single case that there is similar periodontal reduction, reduced less increase in the or greater clinical attachment level gain or reduced clinical attachment loss was recorded in the buccal aspect of this patient. So this was published in the year 2024. More studies are just still ongoing on this minimally invasive pocket elimination surgery. So what the final things here are, still resective osseous surgery needs to be done to get a final final favorable outcome of a bony contour. And then the more recent techniques are involving minimal invasive uh, elimination of these bony defects. So probably just the marginal bony level contouring, and not involving the traditional osteectomy procedures where you have to take the involve the supporting bone of the tooth as well. And these kinds of recent advances has led to enhanced healing adjuncts of bone grafts and PRF. Then the more advances happening are more towards the patient centered approach, like their comfort, their aesthetics, and long term health. These are the three which has been looked upon in the recent years. And integration with the regeneration techniques has like boosted the resective osseous surgery to the next level. And yeah, and that is gaining more and more traction as well. Yes, thank you. That was my talk on resective osseous surgery for today. I hope it was insightful for everyone, and I hope it helped you understand or revisit resective osseous surgery. Thank you.
Thank you, Dr. Rafaiza. It was amazing clinical lecture. Most of your slides were clinical. That was the best part, so that we could
Yeah.
understand very well. But Dr. Faiza, this topic, resective osseous surgery, is very, very important in theoretical point of view also. If you remember,
Yes.
Yani, when you are in your post graduation or when you are in your undergraduation, there are lots of term, Yani. There is
Correct.
Yani ramping, you have positive architecture, you have
Yes.
negative architecture, this everything. So theoretical point of view also, this topic is very, very important. And also in your exams, like if you are giving your state
That
exam
is
or
a
your PG exam, even in my prometric exam also have couple of questions related to resective osseous surgery. So
correct.
this, apart from being a clinical important topic, theoretically also it's very, very important topic, and you have at least 20 terms which are the favorites for your externals, if you are for your HODs, and also you have to remember this.
I think this acts like a base foundation for your for anything in the oral cavity. Like
Exactly, exactly.
nobody takes care of it as much as it is important, because everybody is worried about filling and how the overall teeth should look. Nobody actually sees what happens under the teeth. So this is what is
Yes.
important to.
Now the
It's a
main question is this:
foundation of the building.
apart from periodontist, how many of the clinicians does this resective osseous surgery? Even I don't think so. Most of the periodontists do this in the regular practice, resective osseous surgery. For me, the toughest part is to diagnose. So what kind of defect it is, even with the help of CBCT also, it is very, very difficult to diagnose which kind of osseous defect I'm dealing with. Until and
Correct.
unless I open the flap, I see with my eyes, it is very difficult to diagnose. So before just
That's what.
going
That's
to
what.
that,
Even
we have a question. We have a question from Iftikhar sir. For vertical grooving, are we supposed to use erotor or micromotor?
micromotor would be optimal, because you have more control over how much of vertical grooving you will be doing. Because in erotor, it like you can go more. It is always better to use a micromotor because you have a better control of how much of the bone can be removed.
Yeah. Dr. Faiza, can we go to your initial slides where you have shown the reflected flap picture?
Yes, yes, definitely.
It's demonstrating the defects very clearly.
uh, Defects you want, or
No, no, no. Yeah, yeah. Can you please go up? Initial slides, I guess, fifth or sixth slide. Yep, yep. This one. The next, the previous. No, not the fenestration distance, where we can see the defect very clearly.
okay, this one.
Yeah,
Previous?
another one, please. No, no, no. Next one.
Yeah.
It's not. Let's. This is probably the 13th slide. 13th slide, please.
Check which is the 13th slide. 13th slide. Okay. This one.
No, can you the slide which you shared with me is different. We can see this vertical defect in one of your acquired osseous defect. Acquired osseous defect.
Acquired Osseous defect.
Yes,
Yes.
acquired osseous defect. I need that slide, please. Yes. Go to the clinical picture, please. Another clinical picture is there. Yes, another. Yeah, previous one. The previous one.
This one?
Yes, this one. This one. Yes, this
Okay.
one. So, so for getting this clean margin, so can you please tell us the steps, clinical steps also, so that it is
Clinical
beneficial for
steps
the
to
people
get
who
the
are
clean
watching.
margin.
How you elevate the flap, starting from elevation of the flap to what all instrument you use for debridement, and also what kind of if you were to regenerate this area, what kind of regenerative material and what kind of suturing method is used in this case.
Okay, so these are so this slide actually shows you three different kinds of defects over here. So if let's talk about the first defect over here, because the bone is looking very clean over here. I think probably that's why you're seeing like why how come to get this axis. So the entire point of flap elevation is it's itself an entire chapter is to gain such an axis. This is the axis, this is the final axis which you need to get when you're doing a periodontal surgery. So the initial incision can be different kinds of incisions are available. Like if you take a circular incision probably, and then you give a vertical incision on the two sides, and then you elevate this flap. When you're elevating this flap, this is a full thickness flap. You're including your periosteal elevator. You're keeping in such a way where it directly touches the alveolar bone, and you lift it in such a way the periosteum is along with the full thickness it comes along. Okay, that's when you get the direct view of the bone over here.
Exactly.
And
In
yeah,
this,
so
to my
once okay, one more thing. So what happens usually is when we do a flap surgery, we don't get this much access because we don't extend it enough. To get
yeah,
this kind of access, it has to be
exactly.
extended one tooth distal to the, like if this is 4-6 over here probably, if this is 4-6, you have to extend your incision up to distal aspect of the 4-7. And
Exactly.
on the mesial aspect, you have to extend it up to, in this case, I think they have extended up to the premolar of the, that is 4-4.
Yes.
So
Yes. Yes. This is very important.
this,
Yeah.
that much of flap elevation, if you have, if you need it, like if that is required, that much of extension of the flap has to be done. That is one thing why this picture is very, very clear, because that much extension of the flap elevation has been done.
Apart from that,
And
if you need to get this kind of clean flap elevation, the first two sittings should be always for the non-surgical procedure.
correct, correct, correct.
Deep scaling, 3 to 4 times deep scaling should be done. Then
Absolutely,
only you will get
absolutely.
that, that crispy incision. So
Correct,
if you
correct.
do that,
Absolutely.
if
Like it should
if
be
you're
a,
elevating the flap, yeah, yeah, please,
it
go
should
ahead. Go ahead.
it should be a inflammation free gingiva. Absolutely
Exactly.
no active bleeding has to be there. It should be a proper knife edged margin where there is like nice adaptation so that you can get the circular incision clear. And even when you're placing the circular incision, we should have to be so careful that we're not angulating it any this thing. It's like directly parallel to the tooth surface. And until, am I audible?
Yeah, 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 yeah.
Okay. I just saw enable internet connect to connect to internet. So that's okay. So especially the circular incision when we are placing, we have to make sure that we incise all the fibers around it. Because what happens is we do the circular incision like this, and we are like, okay, we are done. Now let's go for the flap.
We have lost connection with Dr. Faiza, I guess.
Yeah, I'll check and come back to.
Yeah, okay.
Two more questions which have popped up.
Yes, ma'am. There are two questions which were unanswered. Yeah.
So she'll be joining us soon, doctor.
Okay. Okay. So, as a GP, this question is for everyone who is watching this webinar. So, what difficulties you find in getting that kind of defect, yani clean defect, where you can appreciate how many walls are present and what kind of bone graft is needed and what kind of suturing is should be done. And as a general dentist, not like a periodontist, as a general dentist, what is the most difficult part for the general dentist to get the clear picture, any clear clinical, the clean defect where you can appreciate everything around the tooth and around the bone? Is it the elevation of the flap, or is it the debridement, or is it the suturing? Can we see the link? Solution, just please. Debridement of granulation is very critical to obtain the bloodless fill. Exactly, Dr. House. Yes, yes. Perfect, perfect answer.
Dr. Gauss is an oral surgeon, so we can have further discussion with Dr. Gauss and Shiraz
Yes, yes.
meanwhile, by the time Dr. Fahisa joins us.
Yes, sir. So, Dr. House, can we just discuss something on the armamentarium? If you had a case like this, if you had to do a resective osseous surgery or a regenerative one, so what kind of blades do you use? What kind of periosteal elevators, and what are the instruments which you use to debride the granulation tissue? Do you use any lasers in your clinical practice, or it's only your hand instruments like curates is sufficient?
Assalamu alaikum, Doc. Dr. Kaus here.
Sir. Yes, sir.
So, initially, before proceeding for a case like this, I would first obtain radiographs. So, first thing would be I mean, CBCT, I don't know how useful it is in such kind of defects because in two-dimensional radiographs, the information obtained is very limited. And the best thing for these kind of defects is to clinically see them rather than relying on any radiographs per se. So,
Exactly.
starting with the clinical examination, I would probe all around the teeth to assess for, the clinical attachment levels and if there's any active bleeding on probing present or if there's any active inflammation around the gingiva. So, all this give us a basic idea as to what the underlying bony defect is. Then, initially, as you said, the acute inflammatory phase has to subside before we, take this patient to a surgical procedure. So initial one or two rounds of scaling and deep cleaning and once the inflammatory phase subsides, then there is a shrinkage of gingiva after the inflammatory phase. So we'll get an accurate picture of as to what is the defect there. And then probably I would prefer my hand instruments starting with we can either use a number 15 blade on a Bart Parker handle or we can use a 12C number 12C blade for circular incisions as well. That is good as well. And and reflect a flap where you take a leverage from sound bone and then in one shot you clearly raise a flap, then probably you will see some amount of granulation tissue here, which I would, since I don't use lasers in my practice, I use Lucas curate to curate out all the granulation tissue present there. And once that is done, we'll get a more clearer picture of the bone defect there. And from there on, depending on whether it's a one wall defect, two wall, or three wall, suppose it's a three-wall defect where three of the walls are intact. We can use a bone graft without a membrane, if I'm not wrong.
Yep.
Whereas if it's a two-wall defect, then the bone graft has to be held in place by means of a membrane, because if not, there will be epithelial migration.
Yes,
And
exactly.
once this is done, for the coming to the suturing part, I would use needles strictly which are swaged, which are not eyed, because these end up tearing the papillae. And
Exactly.
preferably, if I'm using a graft, a monofilament suture is preferred, because they don't have the property of capillarity in them. So I would prefer,
Yeah.
but clinically, how feasible it is, I don't know, because monocryl itself is very expensive. Other than that, we can also use proline. Ethylon can be used, but they say that the inflammatory response of ethylon is greater when compared to that of proline and monocryl. So this is
Yes.
how I would like to go ahead for a case.
Yes. You have wonderfully summarized, Dr. House. Amazing, amazing. Yeah. This is
Uh,
Yani. You have
Assalamu alaikum.
summarized it very nicely, step by step, and for the imagination also, it is Yani very easy to imagine the steps which you have summarized it.
Mm.
Thank you
Thank you
so
so
much.
much.
Thank you so much for participating. Thank you so
Assalamu
much.
alaikum, Shiraz.
Yes. Assalamu alaikum, sir. Yes, sir.
Hello, Shiraz. Yeah, I just want to ask actually, Gauss,
Assalamu alaikum, sir. Yes, sir.
what Islam Gauss? You said 12C. You meant 15C or 12D?
Sir, 5012C, sir. 12D, the one with the sickle kind of
No,
thing.
12D is you have cutting end both sides on the both ends. 12 is just one end, internal end. What is
So the
12C? I mean, 15C is okay, but what is 12C?
the one with the sickle shape.
That is 12, on regular 12, no.
Yeah, yeah. Sorry, sir. That is regular 12. I'm sorry for that.
Yeah, that
No,
is
no, there
regular.
is a blade
Yeah,
called 12D. No, no, there's a
There's
blade called
15 and
12D.
15C,
15,
exactly. Yeah,
15C,
15 and
and there's
15C.
a 12, and
and
there's
this
a
12.
12D, and there's a 12D
12D.
also.
Yes, sir.
Oh,
Okay. So
Nair
this
sir,
is just,
once you get used to using this 15C blade, you will never use 15 again. Yani, since last
no, no,
three
no,
to
no.
four years, I have never used normal 15 blade.
I
Naima, Naima.
any
Actually,
day
see,
we would prefer 15.
my experience is any day I would go for 15 over 15C. 15C, I
Yeah,
think,
oral surgeons
only,
maybe 15
only
because 15C is small.
uh, 15C is very small.
Yes, yes.
And the
For
thing is,
perio procedures, 15C is the best.
15C is good, but in terms of handling capabilities, what happens is if you're not handling it properly, there's a high chance of cutting of soft tissues. I mean, when
Yes,
you're
yes,
reflecting
exactly.
in the
You'll
flap or
pierce,
you're
you'll
giving the
pierce
internal bevel
the tissue.
incision, when
Yes,
you're giving the internal bevel incisions, if your handling is not correct, the incisions may go vary.
exactly, exactly. And what kind of periosteal elevators you use, sir? If you would have to reflect and full thickness mucoperiosteal flap, like in case of
My
Mold.
go-to
exhaustosis,
periosteal,
as you said,
I'll
like
show you.
lingual exhaustosis or buccal exhaustosis. So you use the
I say,
normal Waltz elevator, or you have any special kind of
no, no, no.
elevators?
I have my own elevator. My go-to elevator, periosteal elevator is I'll show you Busar elevator.
Okay.
Okay, I'll just show you. I think I'll put you on
Yeah, yeah. Please, 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 please put a photo
video
on the
and
group.
then I will show you. Yeah, it will have yeah, I think my go-to elevator, and I don't know whether you guys can see it very clearly or no, but my go-to elevator is this. Let me just open it. Is it clear?
No, 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 we cannot see it properly, sir. We cannot
It's
appreciate
not.
the shape of the elevator.
Let me just turn it up. I think the camera is a little foggy. Huh? Let me just wipe the camera. 8 minutes. Oh, it's still foggy. Huh? But anyway, I'll post my photographs. I have these are the two photographs. Let me see if
Yeah,
this
yeah,
video
yeah.
is
Yes,
okay.
sir.
I think this video is clear, right?
Yes.
So I
I
had
I know. I
another
think
question.
Okay, okay.
it's not clear.
I
What
got
I'll
it.
do is I'll take a picture and I'll post it in the group. These are
Yes,
the
yes, sir.
two.
Yes, sir.
Yeah, these are the two periaxial elevators. Go to elevators for me for my any surgeries. One is the Pritchard elevator. The other one is the Busar elevator. Okay.
Yeah. Still blur. We cannot appreciate the shape of that.
Oh, I'm
But
really sorry. The
yeah,
thing is,
but I got it. I got it. But it is better you send a clear picture in the group so that everyone can
my
get
bad.
benefit.
I'll
Yes.
I'll put it. I'll put it.
Yes, sir. Yes, sir. I think Dr. Faiza, there is some technical issues with Dr. Faiza. Uh, Dr. Hausia has
Yes.
also left, or she's here.
No, no, I'm here. I'm here. So she
Okay,
just
ma'am.
joined and she left again. So I'm not sure what to do. There are a few more queries which you can answer, Dr. Shiraz.
Yeah, yeah, yeah. Yes, yes, ma'am.
And thankful to Dr.
For
Iftikhar
vertical
as well
using,
for
I
joining
suppose to
us.
use aerotor. Actually, to be honest, clinically you can use aerotor also and also micromotor. I use aerotor. That's it depends upon your experience with this. Yes, micromotor has the speed control with micromotor is good. But once you are used to that procedures regularly, like crown lengthening, we often every alternative day I do a crown lengthening case here, so I'm used to aerotor also. It's not mandatory that you use micromotor only, but the best thing is to use micromotor, but you can do it with aerotor also and micromotor also. The resective shavings obtained from reducing the buccal shells can, yes, definitely this is a best material for your GBRs and your for you can mix it with allograft, because the shavings which are obtained from this buccal shells, we cannot the quantity will not be sufficient to use for a case of GBR. So it is always Jani used in conjunction with the osteo your what do you say, the alloplastic material. Can we see the lingual exostosis reduction procedure, please? That sir, that is with Dr. Faiza's presentation. I don't have access to her presentation. Yeah, debridement of granulation tissue. Yes, yes, Dr. House. Yeah, Dr. House has already explained us about the procedure. It's amazing.
So I
Dr.
had
House,
another
are we
question.
ending this or we are waiting for Dr. Faiza?
Hello, sir.
Dr. Gauss, continue. You can come on.
Yeah. So what do you think, like about Schluger and Sugarman files versus your handpiece for Osseous contouring?
With the you're saying the sugar this sugar and
Sugar and
sugarman
Sugarman.
files and the rotary one, right?
Yes, yes.
Yeah,
Which
in
one do you
initial
think is
stages,
the better?
yes, no, I always prefer the rotary thing. Once you have good control, only once you have good control over the handpiece, then it is better you use because it is time consuming,
Hmm.
and also uh, this thing, you will not get the kind of neatness, the kind of the end result you get with the burrs and different kind of burrs, you won't get that with the Schluger and Sugarman files. We use that in PG, but later on in my clinical practice I have that instruments. I rarely use that, but most of the time, most of the periodontists, they use rotary things only.
But according to you, the biological response obtained from using a rotary versus a Schluger and Sugarman file, which one do you think is better, sir?
So clinically, and again, so clinically, and again, theoretically it is different, and clinically it is different, Dr. House.
Yes, sir.
So I don't think so. Once you are good with this using this hand pieces and all, so I don't think so. There is any reasonable difference between these two procedures. But yes, if you are going with the response, like if you're going on the microscopic level, definitely you have that when you're using with the hand pieces, you have that heat generation thing and all. So always, so in that case, if you're going in microscopic level, hand instruments are always better.
Okay. Okay, sir. Thank you very much.
Yeah.
She's still not connected with us. So probably we'll have to continue the discussion in the group. And also, I think we'll have a short webinar from her as well on the grant she's received from the government as well. So she
Yeah,
had
yeah, I was
obliged.
waiting for that only. Yeah, I was
Yeah,
waiting for that only, ma'am. That part was very important
yeah. She
webinar.
wanted to share that with us, and she's still looking
No,
forward to.
if it's possible, I think we'll wait for another 10 minutes if she can get online because we'll have a brief idea as to how and what the process of applying for the grants can. And later on, she can give a brief presentation about it.
Yeah, she's joining,
Okay, sir.
trying to join.
Okay, okay.
In fact, her discussion was going quite well. Her slides were quite interesting as well. Yeah, she's
Yeah,
coming back.
Faiza
No, no,
is.
the comprehensive aspect of how to apply grants and then how to take the grants, I think we'll have a different presentation altogether. But then let her give a brief aspect as to how she got it and then her experience in getting the grant from the government.
So Dr. Fahiza is joining us, is what is showing us.
She joined as a guest.
Yeah, yeah. From both the sides, she's joining us. With Mangalore and Kashmir, it's always difficult. Yes, Dr. Fahiza, please take over. Even the fibrous resective, those things were new for me. Something what she's mentioned about moat was new to me. I've never studied such things in
Yes,
my
yes, ma'am.
periodontic
Yeah.
curriculum. So too much of new learning for me. So I might have to revisit her presentation again. There's too many new.
Yes.
I have this query, regarding since this fibrous dysplasia came into picture now. How exactly do you people as a periodontist manage these kind of situations wherein they are asymptomatic patients, they just come and then you see a radiograph with mixed radiolucency and radiopacities. How exactly do you approach these kind of lesions?
Sir, radiolucency and radiopacity is in which area? Periapical?
It's cement osseous dysplasias. I don't know either actually. See, I come across a lot of in this part of the Riyadh, I come across a lot of cases with fluoride cement osseous dysplasias.
Yes, yes, yes. The dysplasia. Yes, 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 sir.
Dr.
But
How exactly
the
do
dysplasia
you guys approach?
usually it is at the level of the root, sir, not coronally, right?
So you have coronal as well, and you have roots as well. Now the thing is, if it's mid-level or it's up at the root of the level of the roots, you have this bulkiness, and it appears very similar to the exostosis. And then patient has this saying that there's something bulking up, there's something bulking up.
So you're asking
No,
how we differentiate between an
and
exostosis and
no, not about differentiating. Not about differentiating. How
yes.
exactly do you approach and then your treatment modality in such cases as a periodontist?
Yeah, for these things, sir, I always take a CBCT first. If you have a facility of CBCT in our clinic, then we have to take a CBCT first to just to know whether it's just in response to is a traumatic response or it is something like pathological. If it is pathological, you understand it. Any patient gives the history of something, and if she have pain or she has anything, but most probably this is, I guess, sir. It's like normal exostosis where you just elevate the flap and this thing. But I did couple of cases here in Saudi Arabia for this, but it is a classical case of exostosis. The one which you are telling, I never had this kind of
Am I
I
audible?
didn't see the patient also.
I'll share the OPG.
I never did.
I'll share the, I'll share OPG in the group
Yeah. Please, 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 please. Yes,
so that
sir.
actually you can have a rough idea. See, the thing is, I'll just give you a case
Yes.
scenario. There's a 26-year-old patient, male, he just walks into my clinic and is asking that he's feeling this weird lumps in his mouth, both lingually and as well as buccally, in the mandible. Okay, this is more prevalent in mandible
Okay.
than in maxilla. I haven't seen much in maxilla, but I've seen a lot of cases in mandible. Anteriorly, sometimes it's very localized to only anterior teeth, and sometimes it's generalized, and sometimes it's full blown to involving all the teeth of the mandible, lower anteriors to even third molars. Okay, Now the thing is, the issue is they come to us asking that what is to be done, how should be done. But then the most striking feature is they're asymptomatic. They don't feel any tenderness, they don't feel any mobility, they don't have any pockets. Ideally,
Okay.
what I do in such cases is I just advise for periodic follow-up and observation and thorough oral prophylaxis, periodic oral prophylaxis,
Okay.
because they're asymptomatic. But in
So,
terms of
so
the
the,
periodontal department
is
perspective
the
itself, they have a
yes,
different
the
approach
clinical
altogether.
presentation is different from exostosis, or it looks like exostosis?
Uh, the thing is, I think the best way to differentiate between the exostosis and the fibrous cementosis is the location, I think. Okay, the
Yes,
exostosis
yes,
is more coronal.
exactly, exactly. Yes, yes, yes.
But you never
Exostosis
know.
is the,
You cannot say. The thing is, the exostosis radiographs, there's absolutely nothing. If you
yes,
take a
yes,
regular
exhaustion.
radiograph, exostosis, you
Yep.
cannot differentiate. It just looks like a normal
Yes,
radiograph. But if it is a
exactly.
fibro-osseous dysplasia or cement-osseous dysplasia, you can see both
Yes,
radiolucency and radiopacity.
radio opacities. Exactly. Yes, sir.
So
Yes,
in this kind of
yes,
situation, radiographs play a very important role to differentiate whether it
yes.
is exostosis or fibrous or cement-osseous dysplasia.
I'm so sorry for my internet connection. There's some disturbance on that.
Yeah, welcome back.
Yes, Dr. Rafaiza, welcome back.
You're not audible, Dr. Fahiza. Dr. Fahiza, we can't hear you.
Hello.
Yes, doctor, we can hear you now. Hello?
I guess there is some issues with our internet.
I think we'll end it, Dr. Shiraz.
Yes, yes, ma'am. Yes, ma'am.
Yeah.
She
Shiraz,
can schedule. Yeah, you
I've
can.
just posted an OPG. I've just posted an OPG of my patient. Can you just look at the OPG and then this is what my question is. In these kind of cases, how exactly do you approach and then how exactly do you?
But how did we come to a diagnosis of cementosis dysplasia, sir?
Interesting question.
Yeah, because this kind of radio opacities you have. It can be osteoma, it can be ossifying fibroma, it can be osteoid osteoma, it can be no, it's not, or not condensing
Wait,
osteitis also looks similar, right? condensing
No, it
osteitis.
looks like condensing osteitis, but then we did biopsy for it, and then we sent for the histopath.
Ah,
It
okay,
turned out to be,
okay, okay,
yeah.
okay, okay. So this preferably I will refer it to an oral surgeon itself, sir.
Ema, this is pure perio case now.
So it's kind of periapical radiolucency, right?
Where is the radiolucency? It's radiopacity. You have a big, huge mesial pocket in relation to 4/7. The radiopacity is extending apical to 6, 5, 4, and distal to 7. But incidentally,
Distal
there is
to
no mobility even
okay,
even
distal
with
to
so much of
seven and mesial to seven, right? Distal to six.
apical to 6, okay, apical to
Yes.
4 and 5, distal to
Okay.
7, and but then there's a huge even the distal root of 7 is also involved.
Okay.
But
So
there's no mobility. There's no mobility. Huh?
clinically we have yeah like exostosis in the buccal vestibule, right? In area near the buccal
Yes.
vestibule.
Yes.
So this is an interesting case. Yes. Cemento osseous dysplasia. I have to go through this, sir. I have never seen this kind of case in my practice. Not even radiograph like this. I have seen many cases of osteomas and all condensing osteitis, but not
Oh,
this case. So we have surgical photos for this case, sir. Did you
So Dr.
document or?
Shiraz and Dr. Nair, we'll take the discussion in the group now.
okay. Okay.
So I
Okay.
Okay.
think we
Okay.
have Dr. Faiza again back. It's beyond an hour now. So, Dr. Faiza, can you
Okay,
hear
ma'am.
us? Dr. Faiza, can you hear us?
There is some issues with her connection, I
Yes, yes.
guess.
So I
Yes.
prefer taking the discussion on the group because the
Yes,
audience
yes. And
won't be able to
for the
correlate.
grant, the discussion on the grants, we can schedule in another quick webinar from her, right? Yes. Okay. I thank Global Dental Professional Group for honoring us with this opportunity to host and moderate the session. And I also thank Dr. Faiza for the amazing lecture. And at the outset, I will also like to thank all the members who have participated so actively. Uh, so let's okay, let's close this webinar. And any comment from you, Dr. Hosia,
We'll take the discussion forward in the group, doctor.
in
Thank
the
you.
group?
Thank you both.
Oh,
Yeah,
oh,
yeah.
thank you
Thank you.
so much.
Thank
Thank
you.
you so much.